Much and thank for the presence here. This is the first heart failure summit, and we are very proud for the attendance here for the benefit of the community. My task today is to talk about ARNI and congestive heart failure, and I hope this is not a promotional talk. I'm trying to explain and explore some of the mechanistic theories and mechanism behind the benefit of ARNI, because that was established, and Dr. Chaudhry already discussed some of the evidence on that particular aspect. Now, this is the mechanism why pharmacological approaches to heart failure is so successful. Because if you remember, in the 1970s and 80s, we used milrinone despite the hemodynamic improvement and despite the symptomatic improvement, patient continues to die faster and rehospitalized at a higher rate. But once we understood the pathophysiological mechanism and blocked that, we had a major success in the management of heart failure. If you look at the central sympathetic system with beta blockers, is extremely powerful to decrease the symptoms, improve the survival, and also improve ejection fraction. And looking at the second mechanism of RAAS mechanism and blocking that with angiotensin receptor blockers or ACE inhibitors, we also, as we saw this morning, a major benefit in morbidity and mortality. However, the third mechanism, which is the peptidase inhibitors, we lacked the evidence, and the earlier trials using ACE inhibitors in combination with neprilysin has a lot of angioedema, and the studies was continued early. So we had a 20-year lag of information if that will be of benefit. But once you prevent the degradation of neurohormonal activation, which is responsible for the vasodilators, you will end up with a lot of benefit. And this is the idea behind the paradigm trial, looking at the dual mechanism of inhibition of ARNI in the benefit of heart failure. As you all know, the paradigm trial was published in 2014, and subsequently the FDA approved the medications for congestive heart failure with different indication between Europe and the United States. But in summary, this is a patient population of New York Heart Association between 2 and 4. Ejection fraction started with 40%, but then modified to 35%. They have to have biomarkers of elevated BNP or pro-BNP in the categories that was mentioned here. And then the patients have to be established on ACE inhibitor with a reasonable dose for at least 4 weeks. This is a chronic heart failure medication. Guideline recommended beta blockers and mineralocorticoid receptor antagonists with reasonable systolic blood pressure and reasonable renal function and low or reasonable potassium. Now the study is over 10,000 patients, 2,000 were screened and were not eligible, and we ended up with about 8,400 patients. And if you look at the endpoint, which is the primary endpoint of cardiovascular mortality and hospitalization, was decreased by 20% using the combination therapy compared to the ACE inhibitor. And if you look at the differential benefit between cardiovascular death and hospitalization, each one of them decreased that by 20%. But what cares more is that overall mortality, which was also decreased by 16% in the combination therapy sacubitril valsartan compared to ACE inhibitors. And this is a tremendous benefit to patients, and I consider this is a disruptive therapy, and it was the fastest approval of medications in patients with heart failure through the FDA bureaucracy. And if you look at other endpoints, which is quality of life, was also significantly better with the combination therapy. And if you look at the onset atrial fibrillation or the protocol-defined decrease in renal function, in fact, there was no major problem or difference between the two arms of the studies. In particular, if we look at the deterioration rate of renal function is somewhat better with the combination of ARNI compared to the ACE inhibitors. So this is established safety and also established excessive benefit of the combination therapy compared to the ACE inhibitors. Once you look at the adverse events, your discontinuation therapy was somewhat lower in the Entresto compared to the ACE inhibitors, And if you look at the other parameters of angioedema, airway compromise, there was no much difference between the two arms of the trials. And by this established that Entresto, or LCZ 696, becoming the drug of choice once you have a patient with chronic heart failure who fits the criteria of the Paradigm-HF trials. And with extra 20% reduction in cardiovascular mortality and hospitalization, most patients become switched from ACE inhibitors or ARBs to the combination therapy once they fit the criteria. However, this is a trial of chronic heart failure with established disease and established medications, but once the patient's coming with decompensated heart failure or acute heart failure, what are our choices? Can we start the combination therapy earlier or not? The Pioneer-HF trial looked into this particular subgroup of patients, and it was much smaller trial because you end up with a lot of patients if you need to end up with a mortality data. But the study looked at biomarkers, which is the PNB and proBNP in these particular patients because they are markers of long-term prognosis. And in this particular study, the combination therapy sacubitril valsartan decreased proBNP significantly lower than the ACE inhibitors, even if we initiate it after the initial stabilization of patients with acute heart failure. But what most surprising is that once you have the patient bypassing the 8 weeks, becoming unethical to continue with the ACE inhibitor because of the chronic patients with established heart failure, they would benefit from the combination compared to ACE inhibitors. Once you switch them to the combination therapy, their proBNP even having further reduction going to the baseline of the combination therapy starting from the beginning. So this is suggesting it's never too late to start your patients on the combination therapy once they are out of the acute heart failure. Even if you delay them for a few weeks, you will end up with a lot of benefit from this regard. And this is reassuring that these patients, in fact, they will benefit earlier on in the therapeutic armamentarium between the combination therapy and ACE inhibitors. Looking at what is the differential benefit and the safety of those medications compared to the ACE inhibitor, we found no significant difference from the safety endpoints. However, if you look at the combination of clinical outcomes, there was a significant reduction from clinical outcomes using the combination therapy of sacubitril valsartan compared to the ACE inhibitor. So this is not only biomarker benefit, but also some clinical benefit, and because of the study size, we end up with a combination of clinical benefit. And this is also something that we have to consider about the timing of start of the combination therapy compared to the ACE inhibitors. But what's more interesting in this is what is the mechanism behind this benefit or excessive benefits? We know that the myocardial remodeling is a phenomenon of dilatation and adaptation of the myocardium to stresses. And this stress could be an acute, like acute myocardial infarction. And we know that remodeling after acute myocardial infarction take different phases. The early phase is ballooning of the infarcted segment, which we sometimes end up with aneurysm or akinesis. But the later phase is a global dilatation of the left ventricle and ending up into full-blown congestive heart failure. Or it could be a progressive low insult to the myocardium, whether it is hypertension, diabetes, microvascular disorder, valvular heart disease. And in this case, you will end up with earlier phase of thickening of the left ventricle, which we call it hypertrophy of the left ventricle. And with excessive time and the wall stress mechanism, and you will end up with dilatation of the left ventricle. And you will also end up with advanced dilated cardiomyopathy. So whatever the insult, whether it is acute or chronic, you will end up with heart failure. So our interest is, in fact, to progress, to delete or to reverse this if it is advanced, or to prevent it from the beginning if it is in the early phase of left ventricular remodeling phase. Now, once the Prove It heart failure trial looked into this particular mechanism, these are patients who are followed for a period of time, patients who are having heart failure, and they were followed by biomedical markers and followed by echocardiographic parameters. And if you look at this particular study, if you know that the studies in the United States get a lot of scrutiny how they are followed up, very close symptomatic and systematic follow-up on those patients. And you look at the biomarker benefit from starting the sacubitril valsartan combination on this particular patients, significant reduction with biomarkers very early on, within 2 weeks, and that was maintained up to 12 months after follow-up. And this is reassuring that this medication will carry with it a much better long-term prognostic value. But what's more important is looking at structural function of the left ventricle. There was a much significant reduction in the indices of left ventricular function, whether it is diastolic volume, systolic volume, and that reduction in the left ventricular volumes ended up with a significant improvement of ejection fraction. So what we can say that the combination therapy is associated with reduction of biomarkers very early on, that it was sustained, and this is associated with long-term benefit from morbidity and mortality. But more importantly, it reverses the remodeling process that I talked about, which is the dilatation of the left ventricle. In fact, patients at the end of the study, they have a smaller ventricle and much efficient ventricle compared to if you leave them without the combination therapy. And this is what is much more interesting in this particular scenario, that is not only we have benefit, but we have an exact explanation why the benefit occurs, because you ending up with reversing the remodeling process of these patients. Now, reversing remodeling and improving parameters is extremely important, but what is the patient is feeling is also extremely important. Once the patient is feeling better, you ending up with a lot of response and a lot of benefit and a lot of satisfaction. And looking at the Kansas City Cardiomyopathy questionnaires, there is an early on improvement in the quality of life, and that continues to improve and sustained over a long period of time. And in this particular study was 12 months of benefit. And this is suggesting that we having benefit, we understand the mechanism of the benefit by improving left ventricular parameters, but also is associated with improvement of quality of life in these patients. Let me conclude here and get you a final 2-3 slides here. The combination of sacubitril valsartan decreases mortality and hospitalizations, but also improves quality of life in patients with heart failure and reduced ejection fraction. We understand now the therapy, if initiated earlier, you will have much more benefit. So it should be initiated early, but the trick here is to be titrated to the maximum tolerated dose, considering what we call the perfusion issues, and do we have to start with a smaller dose and progressively increasing the dose. The benefit may be related to reverse cardiac remodeling, which we talked about, and that once you have sustained a reverse of cardiac remodeling, you will have a much longer benefit and sustainable benefit in these patients. Now this slide, you saw it a lot, but I modified it myself and I added that ARNI, in fact, or the combination of sacubitril valsartan will take a strong position in the early phase of cardiomyopathy and treatment of congestive heart failure. And that because of the data suggested by the Pioneer and the Paradigm HF, that those patients will have an extra 20% benefit compared to ACE inhibitors and ARBs. So this is modification. I expect that all the societies will endorse this in the future iteration of guideline-directed medical therapy. If you look at the Europeans, we know that they are an ACC here, that this medication took a high class of recommendation. The only thing is that it should be contraindicated in combination with ACE inhibitors because of the higher risk of angioedema. Similarly, the European guidelines is a class 1 indication for patients with established congestive heart failure. The newer thing that we expect within the coming future recommendation is that early initiation after decompensation once the patient is stabilized and hemodynamically stable. I hope by this short review I did not bore you with the repetition of the data, but at the same time emphasizing much more on the mechanistic benefit of valsartan in combination of sacubitril to patients with congestive heart failure. Thank you very much.
We have time for a couple of questions. Dr. Imad?
Probably you have noticed that using Entresto in Jordan, reaching the target doses of 200 twice daily, reaching the doses in Jordan of 200 twice daily is almost next to zero. So do we get benefit from our hypotensives or borderline blood pressure, heart failure Jordanians whom we struggle to get 100 twice daily or 50 even less? Thank you.
Yeah, extremely important question. What is the best dose? And I think once the patient is started on Entresto, you have to also modify other things because the need for diuretic will decrease, and that will help you, in fact, to raise the dose of the Entresto to the higher maximum dose. At the same time, I think we have also the issue of perfusion versus blood pressure alone, because we care about perfusion, and a lot of patients will be running with ejection fraction 10, 15, 20% with blood pressure of 80, 85 without being hypoperfused. So we should not take a parameter of blood pressure alone. And the third thing, there is a combination between beta blockers and ivabradine, and that will give you a leeway to increase your dose if that's the issue. So a few tuning of different medications, in fact, could help us to achieve the maximum tolerated dose. In fact, I have few patients with the highest dose of Entresto, but most of these patients are starting being hypertensive, in fact. But I think you are right. We have to use different tools and different techniques and maneuvers to get the maximum benefit.
Sure.
Patients with the improved ejection fraction, when do you stop? What do you do for the interest?
The million-dollar question, actually, was that if you continue the same medication, we always get reluctant to decrease medication that was related to the improvement of the patient, unless the patient have a really reasonable cause of their cardiomyopathy, and particularly postpartum cardiomyopathy. Those patients, a lot of them, they improve, and once you decide to take them off the medication, you take them gradually, one at a time, very slowly, with a meticulous follow-up. Patients who had established cardiomyopathy because of ischemic and non-ischemic, I probably will not take them off the medication, because this benefit will stay with them if they stay on the medication. Once you stop the medication, you will have a rebound deterioration, and you may not be able to control them back again. So this is a lifelong medication with exceptions.
But I would highlight here that the Paradigm heart failure study was not an ejection fraction study. I know we care much about the ejection fraction and patients care about it much, but the outcomes were related to the morbidity, mortality, quality of life, and there wasn't an ejection fraction component. We know that from the remodeling data that a lot of these patients improved their ejection fraction. But I have patients who improved significantly, and then when I repeated their echo out of curiosity, their EF was not different.
Yeah.
So there are two components to the question. One, if the medication is helping them, it's probably helping them beyond just ways of improving their EF, probably improving their cardiac output, even if the EF is not improved, or the balance between the forward and the backward flow. Somehow they're overall improving. The second thing is there are not much on stopping medications after improvement on EF of heart failure therapies. We only have a small trial called the TREAD-HF, and the TREAD-HF showed us that 50% of patients can relapse into heart failure again after you stop their heart failure medications, even if they're completely in remission from heart failure, as evidenced by symptoms and biomarkers. Of course, the very reversible causes, the clearly reversible causes of heart failure might be a little different, but I would say it's very risky to stop medications after people improve.
Yeah, I agree with that. And look at the digoxin data, although it has no benefit, but once you stop it, patients deteriorate. So those patients who are really established heart failure medications, I will be very, very reluctant to decrease even the dose, not beyond discontinuation, unless, as we mentioned, it is a pure reversible disease and you get it over with.
Any final thoughts or questions? Okay, well, I would like to thank the speakers very much for a great session. And we will abbreviate the coffee break to 20 minutes. So we should be back here by exactly 11:25. خلينا ناخذ معك صورة.